I'll be doing a modified NATS test, which helps look for microfilaria circulating through the bloodstream. Specifically, we want to look for Dirofilaria immitis, which is the infectious heartworm. We want to make sure that our patients are heartworm free before starting any product, if they're on any product annually, just to make sure that the product is effective, or if they do unfortunately have heartworms, which is a deadly disease, that we can treat them in time. So I'm going to take 1 ml of blood out and place it in my centrifuge tube. And then I'm going to add 9 ml of the formalin. And then I'm just going to invert that a few times to make sure that the formalin and the blood are completely mixed. I'm going to place them in the centrifuge for 5 minutes, making sure I put these on opposite sides of the centrifuge to counterbalance. So the timer's done, now we can turn our centrifuge off. And while I'm waiting for that to stop, I will go ahead and get my microscope slide ready, got my cover slips ready. Alright, so here is my nicely mixed sample with my pellet at the bottom. And I'm going to pour off the top. With my pellet undisturbed at the bottom. I'm now going to add 1 drop of new methylene blue. Okay. And now I'm going to use my clean pipette to mix it up. And then just take a drop, place it on the slide. Okay, so now we're ready to read the slide of our modified NATS test. So I'm just going to get everything centered and staged right, and then we're going to look at it on the 10x power objective. So now I'm just going to systematically scan through and look for any potential microfilaria. And if I did find some, I would want to differentiate between A. recondilium and D. immitis. So far, I'm not seeing anything, which is great. So that completes our scan, and I did not see any microfilaria. I'll be showing 4 fecal examination techniques, one of which will be the direct smear, which is the simplest of the methods, but due to the small sample size, eggs and parasites are often missed or distorted. I'll be showing standard flotation, which uses the specific gravity of a flotation solution to bring eggs and cysts to the top of the meniscus, which we'll see after we put the cover slip on. I'll also be showing a centrifugation of a fecal sample and then flotation of that, which actually takes less time than a standard fecal float and is more sensitive and brings more eggs and cysts to the top of the meniscus. And then I'll also be showing sedimentation, which is used to find heavier parasitic eggs and is the most sensitive test that other flotations and smears often miss. It's used generally for large animal parasites as well as any time a fluke infestation is expected in an animal. So for our direct smear, we need our microscope slides, our cover slips, our stool sample, and saline. I also brought a piece of paper just to make sure that we can read through the sample. So we're going to start by taking our slide, placing 1 drop of saline on it, using just enough of a sample to equally mix with our saline. We're going to make sure that we take out the larger chunks. And then we are going to place our cover slip over our sample. And then just showing that we are thin enough, back in the light, thin enough that we can still see the print through the slide. Simple fecal float. I have my fecalizer, my float solution, and my stool sample, as well as a wooden applicator to push the fecalizer down so I don't splash it all over my face, and then my timer to make sure I let it sit long enough. And I also have my glass cover slips that I can put on the meniscus. So I need to first fill the fecalizer about 2/3 of the way full with the solution until it gets to the bottom of the arrow. Alright, and then I need to get about 2 grams of a sample, so I just do a nice smush. Okay. And then I place it into the fecalizer and just kind of twist it around, mix it up so that I make sure that any eggs or parasites can start to come out and float. And once it is mixed nicely, I'm going to use my tongue depressor to push it on. And then I need to fill it the rest of the way to make the meniscus. And now that I have a meniscus, I am going to place a glass cover slip over it. And start my timer. Alright, so now that time is up, I am going to take my microscope slide, take my glass cover off, place it on the slide, and then now it's ready to be looked at under the microscope. Okay, so for my fecal centrifugation with flotation, I have my microscope sides, my cover slips, my stool sample, a cup and a wooden applicator to mix the stool sample with the fecal float solution, and then I have my strainer to put into the centrifuge tube. I also have my counterbalance centrifuge tube ready to go. So I'm going to start by grabbing about 2 grams of the stool sample out. And I'm going to add my flotation solution. I'm going to mix this until it's thoroughly mixed so we don't have too many chunks. Now that that's mixed, I'm going to go ahead and I'm going to strain it through into my centrifuge tube. And since I've got a little more of my float solution than my centrifuge, I gotta add a little more. So now that they're balanced, I'm gonna go ahead and centrifuge them for 5 minutes. Got the timer set, and we can start. Done. Centrifuge off. And now what I'm going to do once it's done spinning is I'm going to take my centrifuge cones out. I'm going to add more of my fecal float solution to my sample until the meniscus forms, and then I'm going to place a cover slip over it for about 10 to 15 minutes, and then we will move it on to the microscope side. Turn it out. So now that it's spun down, we're going to add just enough of our float solution to form a meniscus. Okay. And then we take our cover slip and place it on the top. Great. And we're going to let that sit for about 10-15 minutes. And so now that it has been sitting long enough, we're going to go ahead and take our microscope slide. Take the cover slip off carefully, place it on our slide, and now this is ready to be read for any eggs or parasites. Okay, for my sedimentation, I have my microscope slides, my cover slip, my stool sample. I have my conical centrifuge tubes, one of which I already have water in to help counterbalance when we do the centrifugation. I also have my strainer, so and my cup. I have my tongue depressor. I'm going to take about 2 grams of stool matter out. Going to mix it with tap water. Next, I'm going to go ahead and strain it into the centrifuge tube. So now we're going to place them in the centrifuge. Have my timer set for 5 minutes. A pipette, which I will use to pull a small sample of the pellet at the bottom after I pour off the top onto our microscope slide, and then place our cover slip over, at which point it can be microscopically examined. Alright, so my counterbalance tube. And then my sediment. So I'm going to pour off the top, being careful not to disturb that. And now I am going to take my pipette, take a drop out, and place it on the slide. Place my cover slip over it. And now it's ready to be read as well. There are several methods that you can use to collect urine, one of which would be a free catch or voided sample. Second would be cystocentesis, or third would be catheterization. Both of the last two are sterile collection techniques. The technique used to collect urine is going to depend on the presenting complaint of the patient and what the doctor wants to run test-wise. Voided samples are good for just general routine lab work, or if an owner needs to catch urine at home, voided samples are okay. If we're looking for sterility and samples, which are coming from either the catheter or from the cystocentesis. So to free catch a sample of urine, you're going to need a collection tray, transfer pipette, and your container that you want to put your urine in, as well as gloves as your personal protective equipment. You're going to want to preferably catch first morning urine, because it's going to be the most concentrated urine, and likewise you want to try to catch midstream because you want to avoid the contamination from the distal part of the urethra. Alright, so there I've caught my midstream urine. We have our sample. We're going to transfer it to our sterile urine tube, even though our sample is not sterile. Sophie's urine is very light, clear yellow. For cystocentesis, you will need gloves for your personal protective equipment, your collection tube, a sterile syringe with a cysto needle, so generally a 22 gauge needle that's at least 1.5 inches long, and then we do have another needle that we use to transfer the urine once it is collected to avoid contamination. So what we do, there are a few ways that you can do a cystocentesis. First one will be a blind stick, so whichever the patient whatever recumbency they're in, so a dorsal, lateral, or standing. For females, you would go to the ventral midline, just caudal to the umbilicus, and that's where you would insert your needle. For males, you would make sure that you're caudal to the umbilicus but to the side of the sheath of the penis before entering into the bladder. Aspirate back and then again switch needles before putting it into the collection tube. Another method would be isolation after palpation. So that would be palpating for the bladder in whatever recumbency the patient is. Once you've palpated it, you want to isolate it and then go directly into the bladder, aspirate back the urine, and again transfer into your collection tube. Generally try to always use at least a 10 ml syringe, so I like to grab the 12 because that's the closest thing I have to is 10. And then the last way to do a cystocentesis would be with an ultrasound. So you are going to locate the bladder with the ultrasound and then carefully insert your needle towards the probe until you can see your needle inside of the bladder on the ultrasound, and then you're going to aspirate back, collect your urine, and again switch your needles to avoid contamination before putting it into your collection tube. With the ultrasound guided cystocentesis, you would want to do it on a full bladder preferably, and make sure that you're inserting the needle dorso-caudally to the patient. Monse is going up so that we can do a cysto on our patient here. So she is going to locate the bladder with the ultrasound. She has her sterile syringe with a 1.5-inch needle. Then we also have our needle that we will change before putting it into our collection tube for contamination. And she's going to enter and go caudal to get the sample. This patient's here because so she's got the sample. She's going to go ahead and recap it. And then I will go ahead and so much. His urine is very dark yellow. It is clear, not cloudy. We can see through it and read through the other side. The method of urine collection is going to be catheterization. There are a few different choices to your catheters. The first would be a Foley catheter, which is a catheter that can be used long term and placed indwelling. So for any time that you want to make sure that the urine output matches any fluids going into the body, or you need it overnight for a PU or any other sort of urinary situation that calls for an indwelling catheter, you use a Foley catheter. Other options include red rubber, which is a very flexible tube made of latex, or you can use the polypropylene catheters, which are semi-rigid plastic catheters. But for either method that you use, you're going to want sterile gloves, sterile lube, 2 sterile syringes, because you are going to want to discard the first few milliliters of urine prior to collecting the rest to avoid contamination. The gloves should be for whoever is extruding the penis. And then you also want to have cleansing solutions. So I have my patient ready to be catheterized, and before I get him in full lateral recumbency and open up all of my things, I want to make sure that I'm measuring the proper length of my catheter. So generally from where the bladder would be curled around from the urethra, looks like it's going to come out about there, and I'm probably going to cut it a little higher just so that I make sure I get good suction onto my syringes. So I'm going to go ahead and open up my sterile field. Very good. So I have my sterile lube that I'm going to pour onto my surgical glove site since it is still sterile. Just get my catheter opened up just enough that I can grab it but not touch it. Open up my syringes. First one is to discard the first few mils of urine that I get to avoid contamination. And then the second one will get the rest of my sample, and then I have my needle to put on before I put it into my collection tube so that I avoid, again, further contamination. And then I have sterile scissors to cut my sterile catheter. And then if we can get his penis extruded, I will go ahead and clean it with Chlorhex and then flush it with some saline. And just a little squirt of saline just to make sure we stay clean. So I'm going to head and glove up and get everything going.
Can you pull the plastic back a little bit when she goes to get her hat?
So now my gloves are on. And then
Sheena's going to pull the plastic.
she's just going to pull that up so I can sterilely grab my catheter. I'm going to go ahead and cut it to ensure that it fits over my syringe. Which it does, great. And then the most important part is making sure that we lubricate our catheter so that we don't hurt any of the urethral mucosal lining. Alright, ready? And then just gently feed it. If I feel any resistance.
Here by my finger, so I'm loosening up a little bit. You should go.
So we've got a good feed.
It's okay, Tom. It's okay.
And based on our measurements, I do still want to go in a little bit farther. Should be right about there. Right?
Good boy. I know. You're doing it. Good job, honey. Good job. All right.
And lost some of it, so I'm just going to slip that back in.
You got it, too. There we go.
And there's the rest of our sample. And I want to pull it out gently, making sure to keep towards the end so that I do not squirt urine everywhere.
Good job.
Great.
Look at that.
And then take this off. I'm going to go ahead and put on my sterile needle.
Yeah. So this you can always, if you're just tiny parts, you can always
Insert into your tube.
on these scratch pieces of paper, stick his name on, take some tape.
And I took a little more than I needed, so I'm not going to put all of it in my tube.
Yeah, that's where that goes. Okay.
Discard my sharps. It's very bright yellow, clear urine. So signals that would warrant doing an ear cytology include head shaking, head tilting, any sort of redness, swelling, any dark exudate, or any other presenting complaint that makes us think that their ears are itchy. So to properly collect our samples, we want to hold our ear pinna up, stick the Q-tip into the canal, making sure that we're not going too deep. I know. So that's my right side, and then as we go. There's a little girl. And then I always snap so I know my left from my right. And now that we have our samples, we can go roll them out and take a look under the microscope. We've collected our sample swabs for our ear cytology. We're going to go ahead and run it. We do always want to check both ears, even though a dog or cat may be presenting for an issue in one ear. We want to make sure that we're taking care of both ears. There is a chance that both ears could be infected, so we always want to check both. And if you could not see from the last video, I made sure I went deep enough into the ear canal to get a representative sample, but not so deep that I was packing down material. So here I have my glass slides. I have my ear swabs that we took from the room. So first we just roll them out. I always do the left on the left, and then the right on the right. And then we use a lighter to heat fix it. You want to go a few inches under so we don't burn anything, but what this does is it helps fix the material onto the slide, and also if there are larger chunks of earwax, it will melt it so we can actually see through the slide. So now that that is prepped, we're going to go ahead and put it through our dip quick, and we just need to do 5 dips into each color. I like to blot mine after each color so I'm not mixing the stain if at all possible. And now that we're done dipping, we're going to go ahead and just rinse the back off to get any extra stain off. And now we are going to let this dry, and then we'll take a look under the microscope. So now that our slide is dry, we're going to go ahead and take a look under the microscope. Proper position it onto the stage. I always start with my left and work my way right. We're going to get it into focus using all of our knobs. We're going to raise the stage, get our focus in gear, then we'll move through our objectives until we get to our oil immersion layer, so that we can use the oil to see if there are any bacteria, yeast, anything like that. So, raising my stage until I visualize, fine tune. Alright, now that everything is in focus, we are ready for oil. So we do just 1 drop of the immersion oil, and then take a look. And now we'll move to the right ear. So another drop of our immersion oil. Get us moved over. Okay. And the right ear is negative for yeast and bacteria. So rare yeast in the left and nothing in the right. Skin scraping is done whenever external parasites are expected or suspected in a patient. The area that we scrape is going to depend on where any lesions may be or where the suspected parasite may live on the body. The scraping depth depends on what kind of parasite is expected. If we're suspecting a mite that lives within the skin, you're going to want to scrape until you get capillary blood onto your blade. And if it's a mite that's suspected to live on the skin, you're just going to scrape enough of the skin so that you superficially so that you just get some scales and crust off. For my skin scrape, I have my microscope slides, my mineral oil, my cover slips, and my number 10 blade. So I'm going to start by putting a drop of the mineral oil on the slide, opening up my number 10 blade, and I do want to put the tip of the blade into the oil before scraping, and I want to make sure I'm always scraping perpendicularly so I don't accidentally cut. So we're just going to scrape right here, and assuming that there's deeper parasites, we are going until we have capillary bleed, and then we go ahead and rub it in our oil, and then we will take a look under the microscope. Let's get my flip. Take a look at our skin scrape under the microscope, and we're going to place it on our stage and then look at it under the thorax.
And so they're like, because criminals will say that word, and you know, so that was the trigger word. So, and they were like, don't say this word around that time. And it was like, oh my god, we were going to say is that.
So we're in
So we
view.
went outside and like said it 15 times. That's hard. It was.
Got some hair,
It was like
some skin cells.
I was gonna say, so what if you're just like, get off? You know, most of my conversations at work don't have that in there.
More hair. Alright. So that completes our scan, and we are mite free.